Thank you for the privilege of the podium. So before we get started, I just wanted to go back to some basics about terminology in terms of donation, organ donation at large. Really, there's two big concepts here. One, the conventional donation after brain death, a very conservative method, and now DCD, donation after circulatory death, usually considered a bit more high risk because it means that the heart will rest on its own in normothermia and be subjected to this warm ischemic time, which is often considered very deleterious for the heart. In Canada, currently, we're still only doing donation after brain death for heart transplant in particular, and yet we know that there is a stark imbalance in supply and demand for our donor hearts, particularly in the pediatric population, where the percentage of patients who die who are withdrawn due to clinical deterioration is double that in adults. So in 2018, a bunch of specialists met in Ottawa and concluded we should be doing DCD heart transplant. However, since it's higher risk, it needs to be supported by a different type of assessment modality. Enter this concept of direct procurement and perfusion, or DPP. It's thought that with the introduction of DPP to facilitate DCD, there'd be an increase in the donor pool, about 30%, from what we've seen from our neighbors down south and also in Europe. So, all is to say, DPP, figuring that piece out, is very important for us to introduce DCD. Now, DPP is in a way synonymous with the idea of ex-vivo heart perfusion. Essentially, the heart rests on its own through this functional warm ischemic time, gets taken out, taken to the back table and cannulated, and then warm blood is circulated through it while it's on transport to the recipient's center. Many of you probably have heard of TransMedics OCS, organ care system, that does just that. However, there are two limitations to OCS. First is the fact that it's only compatible for donors that are greater than 40 kilos. Secondly, it follows a Langendorf model, whereby reperfusion is done in a retrograde fashion, which means that the LV is actually not fully loaded, precluding a real physiological assessment for ventricular function. So at Sick Kids over the last couple of years, what we've done is establish one, a pediatric system, and two, a system that allows for both perfusion mode and working mode. So the first question I'm trying to answer is this idea of warm ischemic time. Why is that important? Well, clinically, hearts that exceed more than 30 minutes of warm ischemic time say they take longer to arrest, they're abandoned. So that's 1 in 4, 1 in 5 hearts. But we also know that pediatric hearts take longer to arrest, and they're more tolerant to ischemia. So in the pediatric population, is it possible that we go beyond this 30-minute threshold? My protocol involves juvenile porcine models that are about 10 kilos, around a 1-year-old child, and there's 3 groups, a 30-minute, 45, and a 60-minute warm ischemic group. Spoiler alert, the 60-minute didn't go too well. So what we've noticed, and this is published in literature, is the idea of ischemic myocardial contraction. Essentially, the heart, while it's sitting arrested, it starts to swell, and we see a lack of cavity in those hearts. So in our 60-minute group, we actually only have 1 functional heart that worked and multiple that failed because of that. We've noticed that in perfusion mode, there's an improvement in both systolic and diastolic function, as shown by DPDT max and min, and that there's also an increase in venous lactate as we go through reperfusion. Suggested by this ischemic myocardial contracture, the heart weight percent increase after reperfusion is more prominent in the 45-minute and the 60-minute group, although this did not reach statistical significance. What's really interesting is this working mode. So what we do is we target a cardiac output of 120% and see if hearts can achieve that. We see that in our 30-minute group, all 6 animals consistently were able to achieve 120% cardiac output, while for the 45, it really falls between a range of about 40 to 120%. That one animal that made it to a functional assessment in our 60-minute group had only a cardiac output about 14. So that was the video of what the heart looks like on the rig when it's reanimated. All is this to say that the 45-minute really captures a very interesting population of hearts that have variable function. The function could potentially be recovered and also assessed through ex-vivo heart perfusion, and potentially we can use ex-vivo as a modality or platform to deliver therapeutics and potentially improve those hearts even further. Thank you so much for your attention.